compared to someone who did not have pelvic radiation.
Right, and that's usually the ones that were metastatic. That's why they were getting the big shotgun type.
That and also other kinds of cancers like rectal cancer. A lot of the time they get treated with radiation treatment, and they can get treated for all the lymph nodes in the pelvis as well. Or, not in this case crowd, but a lot of pelvic cancers like cervical cancer, they can get treated to the pelvis. And so we think the rate should be much lower than 5% because we're giving a much smaller. But for whole pelvis radiation, 5% higher chance of a pelvic fracture about 15 to 20 years later.
Thanks.
Yeah, how many patients can be treated in a day's time, usually?
Sure, so each radiation treatment appointment is about 20 minutes long. And so we, at the center, are currently probably treating about 70 to 80 patients a day. We could theoretically go to about 120 patients a day, but the treatment appointments are about 20 minutes
Are those
long.
treatments sequential? In other words, you're doing one person while the other person next is getting ready, and then you
Correct, yes. So we have changing rooms and waiting areas, and so you're in this fancy bathrobe gown thing, and then you wait your turn, and then...
So the patients are treated in a sequential fashion?
That is correct,
Right,
yes,
okay.
yeah. So only one at a time. And that is correct. So, all right, I'll go left to right again. We'll go back to this.
You mentioned radiation right there.
Yeah.
I had IMRT, brachytherapy, and somewhere along the lines, calypso beacons implanted. Would I be a candidate for proton?
We have not been doing proton radiation for prostate re-radiation. I think even with proton being precision, we still have to travel through the outside of your prostate to get to your prostate. And so we actually much more favor either cryotherapy or HIFU or focal brachytherapy if we have to treat just the spot inside the prostate. The problem is that in the modern age, if your radiation treatment was done properly the first time, the odds of the cancer coming back in the prostate and only in the prostate is very low. Most of the time, if the cancer is going to come back, it's going to come back either in the pelvic lymph nodes or elsewhere in the body in the bone. So it's actually very rare to run into a patient where it's back, but it's only in the prostate and nowhere else in the body. So, I saw a hand.
Does VA refer to you?
They do not. So it's a complicated system. So the radiation oncologists at the VA, they're actually part of the University of Washington system as well. So they're my colleagues, they're in my department. I see them at faculty meetings. But the VA is a closed system. And so if a patient who's seeing at the VA wants to be treated, they would have to, have some other kind of insurance like Medicare, unfortunately. It's not part of the VA system.
I really appreciate your response. Original Medicare, I'm in Vancouver, Washington, is becoming more of a non-option. Because the compensation Advantage plans provides for Medicare, people are being pushed into Advantage plans.
Right.
Is there flexibility with Advantage plans under Medicare to come to you?
So, insurance is a whole fund of knowledge that is outside of medical.
The reality
so
that a Medicare recipient most likely will not be able to attend to your approach without private funds.
About half the patients we treat at the center have Medicare. And so I think we're covered under a lot of Medicare plans, including Medicare Advantage plans.
Right.
We've been working hard over the past 5 years to negotiate with the kind of regional insurers. And just in the past year or so, we finally are now contracted with regions as well as Primera to kind of provide coverage. And so I don't know the specific answer to your question, but many of our patients are covered. So only about 10% of the patients we treat at the center are self-pay, meaning paying out of pocket to be treated at our center. So I saw other hands. I think you're next.
I'm a patient at Dan Lynn's, Dr. Montgomery, and Dr. Russell. My next step for me, I'm 51.
Sure.
Advanced prostate cancer, prostate, lymph nodes, and a spot on the pelvic bone when I was diagnosed a year ago. I've been through chemo. The next process is, my next step is to schedule proton beam with Dr. Russell. What should I expect for the whole process?
Sure. So I think, you know, we talked a little bit already about what the side effects are from the treatment, both during the treatment itself, the
I'm gonna
urinary
get
irritation, you know.
7 weeks of treatment.
Yeah. So it's,
Five of all 3 areas, the pelvic, the lymph nodes and the prostate, and then just the prostate the last 2 weeks.
so I think, you know, historically, when the cancer has made its way outside of the prostate, years and decades ago, we used to not treat those patients with radiation because it's felt that if the kind of horse is already out of the barn, radiation is only a focal treatment. We can only target specific areas. So if there's other spots, we can't target them all. In the more recent years, we've learned that with prostate cancer, fortunately, it's a relatively slow-growing cancer. So even if with radiation, we can only treat 99% of your cancer, not 100%, it is enough to be helpful in terms of slowing things down so that you will live long kind of with the cancer. And so we are starting to be more aggressive in patients who even have metastatic prostate cancer, especially in younger patients who have long life expectancies, to use radiation to go after all the spots, which it sounds like is what Dr. Russell is doing. I think, you know, in terms of the treatment, the way that it's going to be done is you'll have to see Dr. Russell again. He's going to do a CT scan so that he can plan the radiation treatment. For you, it sounds like they would want to treat all the pelvic lymph nodes in addition to the prostate itself. And so during the weeks of treatment, you're going to feel more urinary irritation from the radiation. You may potentially have a little bit of diarrhea as well because you have a lot of bowel in your pelvis. And so when we're giving radiation to the lymph nodes in the pelvis, the bowel gets a little bit of collateral damage. So you can have some diarrhea from that. And you're probably going to be feeling more tired from the radiation treatment, partly because you're probably on hormone therapy as well. And the two together makes people a bit more tired than just radiation by itself. So that's kind of what to expect during the weeks of radiation in itself. And then long-term side effects, you know, we talked about the urinary function, the bowel function, and the erectile function, which if you're on the Lupron, it's going to be hard for you to notice that coming from the radiation side. Is that what you were asking?
Yes, I believe so.
Okay.
Did you have any questions?
I thought there were other hands. Okay.
The Proton machine, is that like a big camera?
Good question. Oh, I should have had a picture. So the proton beam comes from a massive machine called a cyclotron. It's about the size of a building. And so when the Proton Center itself is kind of this standalone building, and all along the side of the entire length of the building is actually the proton machine. And so it's 3 stories high, kind of encased. And what it does is basically the proton beam machine, the cyclotron, shoots out these really, really strong proton beams along the length of the building. And we have these massive magnets that then bend the beam into each one of the treatment rooms in the Proton Center itself. And we have a lot of things that modulate the strength of the beam so that, you know, it goes as far as it's supposed to go and no further in the body. So what you see in the room is basically this square looking like a massive camera, I suppose, if the lens was like this big. So
How many treatment rooms do you have?
we have 4 treatment rooms.
Is there a way of measuring the density of your, some people are built strong, they're buff, they worked out 4 times a week at the gym, so they're gonna have more dense muscle. Wouldn't that affect the distance of that beam traveling?
It does.
Versus...
That's why we do the CT scan. So your fat and muscle
fat.
actually look different on the
Let's say if
scan.
you're just all fat and no muscle, it's gonna go through a lot easier. So how does the CT scan depict? No, I get a little trite.
Yeah, so here, I'll kind of show you. So this gray line, very thin gray line is skin.
Okay,
This dark gray is fat.
right,
This is muscle.
right.
And so this is
Oh, I
one
see.
particular
Right.
scan,
Yeah.
but when I think of the range of patients, you know, there's a lot more fat sometimes, and there's less fat sometimes.
Yeah, you go
So
3D all the way.
We can actually see and
Okay.
calculate and
And then
compensate
you
for it.
make,
So-
you adjust and make up. for
Right,
it.
so you are correct, muscle is
fact-
not denser than fat.
Right, you call it factoring.
So is obesity an issue with having this done? if someone's morbidly obese, could they still have proton beam therapy?
We have not yet had any patients not be able to be treated because of obesity. So the radiation beam, you know, the strongest proton beam can only penetrate about 40 centimeters into the body. So our strongest beam. So your prostate needs to be reachable within that distance. The fortunate part of the anatomy is that for most men, you're skinnier where we're treating you on the upper thigh than you are maybe further up. And so we have not run into that problem yet with any of our patients. So, yeah.
Since they went all the trouble of making this big building and this big cyclone thing, couldn't they make an adjustable pan or a hose, so to speak?
Yeah, so they've actually been doing that. So, you know, I think the earliest proton machines that were made, including ours, are these big buildings. And in the more recent years, just within the past year, they started selling these single units. So it's still pretty sizable, but it's now kind of a one-room thing, so that it fits inside a tall room as opposed to a tall building.
If you had this something that was movable, couldn't you open up your body and stick it in there where you miss all those organs that you want to?
Sure. Yeah, so I think, you know, with proton beam, it hasn't gotten quite that small yet. But so we actually, at the University of Washington, we do something called intraoperative radiation, which is when patients are having surgery, we actually wheel in a little portable radiation machine and we kind of do the radiation right there. It's called a Mobitron, so it sounds cool. I think so. But yes, it's a little mobile radiation machine. And so I think, you know, we tend to do that for certain kinds of cancers that are very invasive, so that the surgeon thinks when they go in, they can't get it all. And so we kind of try to clean up right there. With prostate, you know, your surgeon should be able to get it all. You know, it would be unusual to have a prostate cancer that's so advanced that your surgeon doesn't think they can cut it out entirely.
I got a stupid question. Have anybody thought about transplanting a prostate? A good one out of somebody?
That is a good question. I don't know the answer to that. I have not heard of anyone transplanting a prostate. That doesn't mean it doesn't exist. I think the issue is that I'm just imagining what is that you want from your prostate, right? So what you want, I'm guessing, are things like urinary function, which the prostate doesn't really help you urinate. And in fact, a lot of the time it makes it harder to urinate because it gets bigger and it squishes on the urethra. If you want it for erectile function, the problem is that to get the prostate out, you have to cut all the nerves. And so you can try to suture it in someone else, but I don't think the nerves kind of work that way. And so I don't know what you would get from a transplanted prostate.
Right, there's more nerves than there are veins, so it's catch
You might
22.
get prostate cancer twice.
Yeah. That is also a possibility, yes. So.
We talked about the beam and the gel. Is there any work done on it, something you can take of that would make the prostate more receptive to the radiation?
Yeah, so there's been quite a lot of work on looking at both radiation sensitizers, making the cancer more sensitive, or radiation protectants, making your normal cells less sensitive.
Okay.
The problem has been that it is extremely difficult to find something that does one or the other to just either cancer or your normal body. So for example, there is a drug called amifostine. It's FDA approved and given for radiation protection. And the problem is that it also protects your normal cells a little bit, but hopefully a little bit more than it protects the cancer. So there is a slight difference. The downside to the drug is it's pretty toxic. It causes a lot of dizziness, lightheadedness, nausea, and so patients that take it, we observe them at the center for like several hours after they take it on a daily basis. So from a practical standpoint, it's just not very practical.
Wow.
In terms of making the cancer cells more sensitive to radiation, you know, we are pretty good at giving a high enough dose of radiation that it pretty much kills what's in the prostate, and so it's hard to find something that, again, it's about you have to be able to only protect the prostate, you know, only like normal cells, or only hurt the cancer cells, and it's hard to find something that only does one without doing the other.
Okay.
So I thought I saw more hands.
Yeah, I got a question. Between proton
and CyberKnife.
Yeah.
What's the difference really there?
Yeah, so I think CyberKnife is using regular radiation, but it does it by using very, very tight beams that are focused right around the prostate, so that even though you still get kind of that arc distribution of radiation, the red portion is extremely tight around the prostate. And so I think when we talk about kind of comparing the two, the total radiation dose to your body is still about lower with proton radiation than it is with CyberKnife. But CyberKnife, because they are trying to be a lot tighter and narrower, it's given a lot faster. So it's usually given in 5 treatments. So, but the total amount of radiation to your body, the pictures still look about the same, even with CyberKnife. But the red area will be a little bit smaller. There are clinical trials looking at using proton radiation to give CyberKnife-like treatments, meaning we radiate the prostate in 5 treatments with proton radiation. We've been concerned because that's kind of been a newer thing that they've been doing. We'd like to see more results to make sure that it looks as good as the longer course before we start doing it. Does that sort of answer your question? Sort of.
So
All right.
why doesn't the insurance industry lighten up on proton therapy when it's pretty well substantiated that the old school radiation treatments aren't doing much good for most patients? So why don't they lower the jumping bar or the scale so they will cover it like United Healthcare?
The language that they always use is that, one, it's experimental, which I think it depends on how you define the term experimental. It's been used for decades. We've treated hundreds of thousands of patients all over the world with it. It's not really experimental. But the second argument that they'll make is it's more expensive. So you need to show me randomized data that proves that it's better.
Well, that could take 5 years then.
So it takes
Or
a lot
10.
longer
They
than
could
that,
say, well, give me 10-year studies.
And so many of us are frustrated because when Loma Linda started doing this a couple decades ago, they did not have insurance coverage issues. So they did not face pressure to prove that it's better. And so they didn't do any randomized trials.
Oh.
And so they publish their results and say, you know, this is how our patients did and it looks good, but it's not randomized head-to-head against regular radiation.
Oh.
And so now, proton centers, us included, we're faced with the pressure of proving to insurance companies that it's better. So we're doing randomized trials, we're doing that as well. But the problem is you're kind of in a catch-22 because the clinical trial, there's a national need for it, and even the National Institute of Health and the National Cancer Institute recognizes that, and they're funding running the clinical trial.
Right.
But insurance companies still refuse to cover the treatment. So they say, there's no evidence. So we say, well, we're doing the trial, can you cover it so we can generate the evidence? And they say no, because there's no evidence. So you're kind of in this little loop.
Yeah, I feel for you.
Yeah.
Because I know those trials are not cheap. And that's why
They are
they increase
not.
the cost of the treatment if you do decide to.
Yeah, and I think that was probably the very last slide of my PowerPoint, which I didn't go into, which is we have the trial open. It's a national trial at a lot of proton centers. It's called PARTIQL, and it's looking at quality of life after proton radiation versus regular radiation, trying to show superiority, or not, either way, to answer the question of what is the quality of life after proton radiation versus IRT radiation.
Okay.
So
Thank you.
I saw more hands.
Yeah, earlier in tonight's discussion, I heard, I believe from this side, that it would cost $9,000 a day
Yeah.
for treatment, is that correct?
Yeah.
So in medicine, there's this odd phenomenon of we bill some random retail price, and your insurance company will decide some random discount from that retail price with which to pay us. So I think if I'm remembering correctly, Medicare pays us about $1,500 a day for your proton therapy treatment, which is about 20% higher than what they would pay for your IMRT treatment per day. So there's a slight difference, but it's not like, you know, we're like 10 times higher. I think when you pay out of pocket, for example, for the treatment, I don't know what the exact numbers are, but we're probably talking more on the scale of like $60,000 for the course of treatment out of pocket, no insurance coverage. And so that divided by 9 weeks of treatment for whatever that is. So,
Okay.
How about buying for treatment with CyberKnife?
I do not know. So again, it's the kind of thing where your insurance company will pay one price, but if you want to pay out of pocket, it will be a different price. So
Would be
it
cheaper.
depends on. I would guess that because it's fewer treatments, we're probably talking something more like 30 to 40,000 out of pocket for that. It's unfortunately not a per fraction discount, so it's not like you divide it by 9 and it's only $5,000
You're on
or
camera, this
something.
is great.
It's a 30 to 40 probably, my guess.
Well, does Medicare pay 100% then, or?
My understanding of Medicare is that it pays for 80% of whatever it is that you're getting. And then it's up to your supplemental or not to pay for the rest.
Okay, one more question. Anybody else?
Right.
I'm happy to stay for a few more minutes
No,
and
no.
ask and talk as well.
I understand you say that weight and size is not a factor. And the reason I asked the question is because I had a friend who made preparations and arrived at Loma Linda and they told him he was too large.
Oh, interesting, okay, yeah.
But with you, that kind of not a problem.
So, I mean, Loma Linda's Proton machine is about 20 years older than ours, so their technology is a little different. I don't know what size your friend is. All I can say is, so far at our center, we have not seen any patient that we cannot treat.
6'4", 280 pounds.
Oh, no, we've treated patients much larger than he is, so, yeah.
All right. Thank you very much.
Watch it again over and over if needed.
Yeah, that's right. Appreciate you fighting the traffic.
Not a problem. I'm happy to stay for a few more minutes and talk as
If
well.
anybody wants
There's more
to ask her
questions.
one-on-one.